Hi, my name is Lily,
And my name is Ramisa.
and today we are presenting the Youth-Centered Adult Allyship Prototype from the Minds Lab.
Mental and substance use disorders are the leading cause of years lost to disability in children and youth worldwide. Specifically looking at the youth in Canada, around 30% of the current population are youth. Of these individuals, it is estimated that 10 to 20% are affected by a mental illness or disorder. 70% of mental health problems have their onset during childhood or adolescence. So that's between the ages of 16 to 25. These individuals are in a crucial period for developing and also maintaining emotional and social habits that are important for positive mental health. Individuals in this age group are facing high volumes of stress associated with transitioning to adulthood, such as societal demands, shifts from dependence to independence, sculpting of personal identities associated with occupation, sexuality, and relationships. So this is where Minds comes in. So who are we? Minds, which stands for Mental Health Incubator for Disruptive Solutions, is a social innovation lab tackling the wicked problem of mental ill health and addictions for transitional age youth. So for the purposes of this presentation, we'll refer to them as TAY. And again, transitional age youth are between the ages of 16 to 25. And we are offering our services to the community of London and Middlesex. The lab employs collective impact approach to collaborate using a youth participatory action research methodology. And to do this work, Minds collaborates with youth and their adult allies in research, healthcare, public health, education, social services, and nonprofit organizations. And we had a convening in 2019. And at this convening, Minds was able to develop a full day event, which was dedicated to youth participatory action research and social innovation for youth mental health system transformation. Approximately 90 attendees came to our event. We had youth and adults from various backgrounds, such as Western, Mind Your Mind, Innovation Works, Welkin, St. Joe's, and the Thames Valley District School Board, and also the Catholic School Board. And there were 7 prototypes that were proposed by the collective, and 3 of them were selected to be implemented and funded by Minds. And one of them was youth-centered ally training.
An ally has been defined in scholarship as a person who is a member of the dominant or majority group working to end oppression in his or her personal and professional life through support of and as an advocate with the oppressed population. In this context, an adult ally would be the older individual with dominant power working with and for youth. The concept of adult allyship is also supported in PIR. PIR is a methodology which argues for inclusion in research with the best approach to social issues being from the knowledge of those most affected by said issues. In a mixed method study conducted by Liegio, the adult principal investigator partnered with an agency in Ontario to form a research team of 7 psychiatrized youth, ages 14 to 17, to explore the stigma of mental illness in child and youth mental health. In this project, adult allyship was demonstrated through including the youth research team through meaningful participation. This involved the adult investigator yielding some of their research power to the psychiatrized youth in order to share the decision-making process. The impact of adult allies in youth mental health has been shown in the literature. This partnership successfully allows both parties to mutually support each other, helps adults understand that youth deserve to have their agency respected, no matter their age, and on a broader scale, leads to the greater good of their community. Our work has focused on the advancement and understanding of our knowledge regarding what it means to be an adult ally from the perspective of TAY with lived experience in the mental health care system and from adults who identify as adult allies. The primary objective of this study is to capture TAY and self-identified adult ally impressions about what constitutes an adult ally, as well as what the youth-adult ally relationship entails. This information will be used to construct a working operational definition, of what an adult ally is with reference to youth mental health.
In keeping with PIR, and Woolley explained what PIR means earlier in the slide, in keeping with this methodology that Minds employs, we worked with Tay to develop a survey that aims to collect feedback on youth and adult allies' impression on what constitutes an adult ally. And the questions we asked were, how would you define adult ally? What does a youth and adult ally relationship look like to you? How do you mend a broken or strained relationship? And the data gathered will be used to inform the development of the Adult Ally Training Protocol, which I'll explain in the next slide. And this protocol will provide guidelines on how adults can become allies to youth. So this is the work that we've done so far. We have worked with Tay and adult allies in the community to create a tip sheet that provides guidelines and steps on how to create a strong and trusting relationship after trust has been broken, and also how to navigate the ebbs and flow of an adult ally relationship. The 6 themes covered in this tip sheet are acknowledge, explore, learn, be honest, rebuild, and finally continue. The results from the survey will help to inform the final iteration of the tip sheet. The survey will help us to ensure the tip sheet best reflects the community's perception on what makes a true adult ally. In regards to our preliminary findings from the survey, currently 22 Tay and 16 adults have started the survey, but unfortunately 12 Tay and 8 adults actually completed it. And for the next 2 slides, I'll present the quantitative data for Tay and then adults afterwards. So 32% of youth have adults in their life that they would consider adult allies. And for the question, would you consider any of these people to be an adult ally in your life? We see that most youth said parents, guardians, teachers, guidance counselors, and counselors, therapists. There's a lower percentage of youth who selected healthcare professionals and coworkers as the adult ally in their lives. And then for the question, how would you define your role in the mental health system? As you can see here, most youth are currently in care, and a lower percentage, 38%, were previously in care or never in care before. And here I'll present the quantitative analysis for adult allies. So we see 50% of adult allies who responded to the survey would consider themselves an adult ally. And for the question, how would you define your role in the mental health system? We see that the highest percentage is seen with parent and caregivers, and lowest, a percentage of 8%, is seen with non-professionals. There's a discrepancy seen between the percentage of youth who consider the adults in their lives to be adult allies and with adults who consider themselves to be adult allies. Less youth consider adults to be adult allies, and more adults consider themselves to be an adult ally.
This survey had both quantitative and qualitative components. For the preliminary analysis, I will focus on these 3 questions. What comes to mind when you hear youth and adult ally relationship? How would you define the term adult ally? And what does an unsupportive ally look like to you? Among both participant groups, the common themes in response to these questions were mutuality, evolving dynamics, humility, and openness to learning. Mutuality was expressed when Tay thought of mutual effort for understanding. Openness to learning one another was highlighted in Tay's definitions of adult allyship through active listening and non-judgmental support. They also had strong criteria for what would make an unsupportive ally, ranging from someone who isn't trustworthy to being an authoritative figure who doesn't want to listen to what the youth has to say about their own experiences. Among the adult respondents, they also recognized the importance of entering an allyship with youth with mutual respect and cooperation, with one parent sharing they will do what they can for their child to have a smooth experience. Adults also understood the importance of humility in their position and seeing the youth as an equal when defining the role, walking side by side rather than speaking for them. This was also shown in their view of an unsupportive ally, someone who has their own idea of how the relationship should be carried out, rather than forming the process together and not presenting their authentic selves. In terms of the research implications of this survey, the findings from this research can help expand and refine the scope of what an adult ally can mean to youth and/or adult allies who engage in this dynamic, especially in the context of mental health. The insights shared from youth can help adults who are active allies self-reflect on how they can improve if they are being the supportive ally they believe they are, be mindful of their biases when interacting with youth, and more. The youth data also highlights the different ways adult allies directly or implicitly exercise their power in the dynamic, even when the ally may mean well. These findings overall can inform adult ally-related programs in hospital and community-based settings, primary caregivers who are trying to understand the agency of the young person in their life, navigating their well-being in the healthcare system, and more.
And for our future directions, the results from this survey will help to inform the literature in this area by developing a working operational definition of what it means to be an adult ally, and highlight where differences between adults and TAE perspectives on allyship may exist. The results from the survey data will also help to inform the final iteration of the tip sheet. Through the data, we'll be able to understand how we need to change the tip sheet to better reflect the community's perspectives. And lastly, once the final iteration of the tip sheet is created, we will work with mental health organizations in the community on the implementation of the tip sheet, and later the evaluation of the use, effectiveness, and impact.
Thank you for listening to our presentation on adult allyship. To learn more about the different prototypes within the Minds Lab, please visit mindslondon.ca.
Hi there, and welcome to our presentation today on promising data in consumer survivor initiatives and organizations, exploring the potential to tell our own stories about our value and contribution. I am Laura Pearson. I'm the Executive Director from Ontario Peer Development Initiative, an organization that is an association of direct service peer support organizations and services. And I'd like to introduce Dr. Tanya Shute from Laurentian University School of Social Work. So our current healthcare environment, the current government has indicated in their roadmap to wellness, the guiding philosophy of healthcare restructuring, the importance of patient voice as many in the rebuilding and restructuring of our healthcare system. We know that there is always a need for data to identify outcomes, to identify evidence, and to identify areas in need of funding. In addition, with the output or with the onset of Ontario health teams that are in different stages of delivery or readiness or development throughout our healthcare system, we need to understand the role of peer support, in particular CSIs, consumer survivor initiatives, and peer support organizations that are that provide service by and for people with lived experience. The impact of these organizations on the Ontario health teams that are, as I say, in different stages of readiness and delivery. Many are already currently delivering services, and some have just been identified as in states of readiness to begin to do this work. The different levels of engagement also of peer support organizations in these different Ontario health teams suggests a different value placed on the importance of peer support, and in particular, again, consumer survivor and lived experience, and the voice of lived or living experience in the healthcare system. OPDI's member agencies across Ontario have had different inputs and have different access to shaping the current healthcare system as it is being rolled out in the Ontario Health teams. Currently, what Ontario Peer Development Initiative has heard from the organizations that we serve. Those are our member organizations. We know that organizations are being asked for different data across the province, depending on the programs that have been funded, depending on when the funding was rolled out, and depending on the region that they're serving. The reports that our organizations are asked for have not always reflected the impact of the work that has actually been done, or the impact of the work that has been done on the people that they're serving and working with. We currently don't have the opportunity or the resources to coordinate the reporting of data. So our organizations typically are small, not well funded, and certainly don't have either a research or an independent data department or even person who's able to coordinate the reporting of data or actually do a deep dive and look at the data in a way that's meaningful for those organizations. They simply report what they're being asked for to reflect the demands of each individual program that's funded. And again, so we're currently producing data that may not necessarily be meaningful to our organization or our peer support sector, or more broadly to our healthcare sector. So the research that OPDI and Dr. Tanya Shute are engaging in is to look at consumer survivor initiatives in the peer support sector data. And the reason we are strategically positioned to do this is that OPDI has heard the call from our member organizations, and we need to amplify that voice. And to do that, we also need data that tells us the outcomes and the impact of the work that we're doing. OPDI wants to take and support our member organizations in taking ownership of the data that they create, so that we can tell the impact of the peer-driven services in the healthcare sector and in the peer sector broadly. So again, it's the focus on the CSI, the consumer survivor initiatives, and the services that are driven by and for people with lived experience specifically, and the impact that they have on our sector. We want to use our data to continue to improve services. We want to demonstrate the effectiveness and to build evidence for ongoing peer-driven services and additional funding to our peer-driven services. Most importantly, OPDI wants people with lived experience to lead. We really want to be directing the impact and be able to speak very clearly about the impact that we are having on the healthcare sector.
Wonderful. Thank you, Laura. So again, I'm Tanya Shute with Laurentian University School of Social Work. But prior to becoming an academic, I worked in the CSI sector for about 20 years. And so I know personally the value of what's being done in this sector. And I can attest to the fact that most people don't know. And that certainly it doesn't get the attention it deserves. So this SSHRC Partnership Engage grant is going to allow me to assist OPDI to get a picture of what's happening across the province in terms of data, and really how to make it valuable for CSIs and the sector itself. We know that these organizations have a tough time, and it's not just Ontario. The literature tells us that these small underfunded organizations are punching much above their weight. And for the most part, especially under austerity economies of service, turn their attention to direct service. Although that wasn't our original rationale for existing, I cover that in the next slide. But the reality is austerity budgets, loss of funding, an increasingly turbulent policy and organizational funding environment means that, especially during the pandemic, most of our service attention gets turned to direct service and serving our peers. And doing that in solidarity and doing that work in terms of also serving people who aren't being served in other sectors, because we're typically low barrier, low threshold services. So there isn't the time or the capacity to spend talking about data and talking about research projects that other funded community mental health organizations by similar funders have the capacity to do, even having research departments. It's not a priority for CSIs. But increasingly they're losing the capacity to engage in systems work, policy work, social change work, and having to direct their attention to frontline service. Also, we know CSIs in Ontario had great promising data in the 90s and early 2000s when the CSIs were originally set up, and there was some academic research interest as well as some lived experience research interest into documenting their work. But since that time, it's sort of fallen off the academic radar. And that means difficult things for the Ontario sector in that they have to rely on perhaps American literature to demonstrate the value and contributions of CSIs to the mental health sector. And we can't tell our local story outside of our organizations. So first, what are CSIs? People may not know this, they may have a very anecdotal understanding of consumer survivor initiatives, but what I want to harken back to is the literature and the research that showed that CSIs were much more than just peer support services. They were peer-driven, peer-led, peer-dreamt, that these were concepts and services meant to be from the lived experience sector, from the psychiatric survivor sector, that really created the momentum for these organizations to be funded. And when we were originally funded in the 90s, there were about 38, 39 originally funded from what we can tell. They were set up to be independent, autonomous organizations that offered services not replicated in other areas of the mental health sector. And that we had two functions: to provide a space, a collaborative shared space based on our values, empowering and liberatory spaces for people to use, not necessarily only services, but spaces for people to use and be, but also provide these social change functions, sit at policy tables, work on systems change, engage in advocacy work. And increasingly that the pressure on our services has become such that we spend much less time doing that systems and advocacy change work in CSIs and focus more on service, putting much more pressure on OPDI to protect our sector. We also want to make the distinction between peer support services and consumer survivor initiatives, or peer-driven, peer-led, peer-delivered services. We know that the services offered by consumer survivor initiatives and consumer-run organizations have a huge impact on the mental health system and on the sector as a whole. We are usually low cost or cost-efficient services, not a good thing. But in terms of value to the sector, we know that we have a huge impact on policy as well as the empowerment of the people who use our services. But peer support services delivered in peer-led, peer-driven organizations are much different and have much better contribution. The evidence just shows us that peer support delivered within these settings is a different offer than when it's delivered as a program in a mainstream or community mental health organization or hospital. Our evidence showed us in the 90s, for example, that we had a very significant impact on reducing hospital days, stays, reducing emergency department visits, shortening or reducing the use of crisis-based services or acute-based services. Chuck in 2002 determined that peer support from local community survivor organizations, or CSIs, led to a much earlier discharge from hospital, up to 116 days, translating to then in the 90s a $12 million save in terms of hospital stays. So for very shoestring organizations, we are having a huge impact on the mental health sector. But also we have some of the similar impacts in terms of increases in well-being, increases in mental health indicators and outcomes as defined by survivors themselves. And sometimes those are the same or the same effect size as other community mental health organizations and services. But what we know from the literature is that consumer survivors say that they prefer our services to mainstream services, even though the outcomes may be similar. But the services in our organizations also led to a more welcoming environment, a more liberatory approach, a more empowering approach that enhanced their mental health outcomes. So we also know that research has fallen off in Ontario since that early 90s and early 2000s work. And it's my premise that that also dovetails with increasing precarity in terms of landscapes. So if we can't provide our own evidence that's local and current, all of our work, all of our amazing work is only known within our sector, and that's a real disservice. But there's also this really, really great piece of research that I'm hoping that we can begin to take up as well. As I've watched consumer survivor initiatives be divested, be amalgamated with other mainstream non-survivor-led organizations, or just closed altogether, or rendered down to the essentialist of peer support services, but losing the peer-driven, peer-led, peer-conceived, peer-dreamt elements of CSIs, there's this really small study that just provides me much hope that when we get our story, when we have our data providing our story, that the personal empowerment of service users is directly related to the autonomy and independence of the organization from which they received the peer support services. So the nature of the organization is part of the effect size research. It is part of what those mental health outcomes are that are unique to our sector. And we hope to provide not only data about what we do and the amazing things that we do and tell our own story. We hope researchers get reinitiated, re-energized for this sector and start to bring more attention and effort to our sector to help us build this current evidence and tell our story as we lead and as OPDI leads that story.
Just to emphasize what Tanya's saying, is that OPDI wants to be leading from the place of lived and living experience. We want to ensure that our healthcare system follows the adage of nothing about us without us. We want to ensure that it is our story that shapes the services and our data that tells us how those services should be implemented, which we fundamentally believe is by and for people with lived experience. I'd invite everybody here to look to OPDI's website and to join us in and support us in our research. If you have questions about research from the perspective of lived experience, we would invite you to engage OPDI in that conversation so that we again can be part of that conversation leading from the voice of lived experience, the sector data and evidence that is so desperately needed to be have life brought back into it and to re-examine it. And so with that, I close the presentation and we'll take some questions. So.
Hi, my name is Alec Cook.
And my name is Lily Yosef, and we are research assistants at the Mental Health Incubator for Disruptive Solutions, also known as the Mind Social Innovation Lab at Parkwood Institute. Our presentation is titled Social Innovation, Youth Participatory Action, and the Youth-Led Interventions from Minds of London Middlesex. Wimax's mission is to promote youth-centered practice in youth mental health care through advising and guiding hospital programs, initiatives, and community agencies and organizations through authentic leadership, influence, and decision-making. Wimax's goal is to promote youth voice and participation that aligns with the goals of Minds to develop and research system-level change leading to the development of meaning and purpose, resiliency, and quality relationships for transition-age youth. Wimax membership is limited to 12 active members, and the council is facilitated by 2 former council members. In order to be considered for membership, interested youth must be between the ages of 16 and 25 and no older than 25 years old at the start of their term, have lived experience with mental health and/or addictions, and commit to attending 1-hour meetings every other week.
WIMAC was created and developed utilizing Youth Participatory Action Research, YPAR. YPAR as a framework is focused on engaging both youth and adults within a community to work alongside one another in a non-hierarchical format, creating and encouraging change in the current system structures that provides benefit to the entire community. The role that WIMAC has taken on is to work with various agencies and organizations in London Middlesex that provide mental health services to transition-age youth 16 to 25 by advising and providing youth voice to improve how youth mental health services serve and engage with youth. YPIR asserts that youth are the experts in their own experience, and Wimax has specifically been structured to reflect this. Members of Wimax are youth who have lived experience of mental ill health, either personally or with a close other. Members are encouraged to use their lived experience to reflect on how the mental health care system can better serve the TAY population. Wimax's use of the YPIR framework is reflective of a new service model where youth experience is seen as a valuable learning aid, which can be used to shape the design, implementation, and upkeep of mental health services used by youth.
Wimax has worked with various organizations in the London Middlesex area, including Mind Your Mind, CMHA, CAMH, and more. Since 2016, the Council's impact includes reviewing and advising on intake forms for a local youth-centered walk-in clinic and collaborating on the content and design of the transition protocol for youth who are receiving mental health services in the youth system and will transition into adult services due to their age. Mind is currently conducting research into how Wimax promotes the development of meaning and purpose, resiliency, and quality relationships in its members. The end goal of this research is to show how Wimax helps its members so that the Council's model can be adapted by other youth. To assess this, researchers from Minds will interview all current models and our current members and ourselves, the 2 Council members.
The main objective of the current Council is to complete and disseminate a peer support guidebook aimed at providing mental health literacy to youth who are interested in supporting their peers with their mental health or addictions challenges. The guidebook is not a self-help book, but rather a resource for youth wishing to start conversations around mental health with other youth who may be experiencing mental health challenges. Written in plain language that all transition youth can understand, the guidebook covers topics such as basic information about mental health, how to have conversations with friends around mental health, and self-care and coping strategies. Wimax Peer Support Guidebook was developed, researched, and written by the Council's youth members. Wimax members wrote about the information they would like to have to support their peers and start conversations about mental health. For this reason, the guidebook is uniquely designed to appeal to its youth audience. At the start of the 2019-2020 term, Wimax members opened up about their shared experience dealing with a lack of proper support during a difficult time in their life or being aware of when they did not know how to help someone else through their challenges. The Council then decided that their main project will be to complete and publish a peer support guidebook for youth who are interested in supporting their peers struggling with mental health or addiction. The following slides are examples of sections in our guidebook.
Across the world, mental illness among young people continues to rise, and it is the #1 cause of life years lost to disability in this population. In Canada, almost 20% of youth between the ages of 15 to 24, also known as transition-age youth, experience mental and substance use disorders. With the ongoing COVID-19 pandemic, youth face more challenges trying to receive support from mental health services. Over 60% of transition-age youth were the most likely to have negative mental health experiences, and over 40% felt moderate to severe anxiety. With this guidebook, the Council aims to have more youth talking about mental health and self-care, to be a resource used in schools and hospitals by youth and their caregivers, and to help youth understand different types of issues beyond depression or anxiety, address myths about different disorders, reduce the stigma about mental health and addictions, inform youth that they're not alone, and help them feel seen in their unique road through recovery.
Chapter 1. Mental health. Everyone has mental health. It is a state of well-being that can range from good, optimal, to bad, poor. A person with optimal mental health has a sense of purpose and takes steps in achieving it, managing the highs and lows of life. A person with poor mental health experiences the opposite. They don't feel like they have a sense of purpose and struggle with managing daily life hassles. If you're having difficulty understanding mental health, think of it as physical health, but for your brain. The more you work out your brain, say taking deep breaths, taking the proper medication, or talking to someone, the stronger your mental health muscle gets. The closer you are to optimal mental health. When you have optimal mental health, you have a sense of purpose, strong relationships, a sense of connection, a sense of self, you know who you are, you can cope with stress, and you enjoy life. On the other hand, mental illness is something not everyone experiences. Just like humans can have heart, lung, or kidney problems, sometimes our brains don't work properly. Mental illness can disturb thoughts and negatively impact a person's day-to-day life through harmful feelings and perceptions. Around 10 to 20% of Canadian youth experience some type of mental illness. Mental illness symptoms can range from low energy and loss of motivation to obsessions and fears. However, these listed symptoms do not fully encompass what an individual might experience. Mental illness can also interfere with a person's relationships and their ability to function, often leading to isolation. As difficult as mental illness might be, people can reach out to receive help. Their close connections can provide support by being present. Some commonly discussed mental illnesses are depression, bipolar disorder, and anxiety. However, there are many more illnesses people might experience. Anxiety is a normal response to something that may be seen as dangerous or stressful and has been experienced by everyone. Feelings of anxiety can be triggered by negative situations, including a health issue or a loved one passing away, and even positive events like graduating or getting married. Whether positive or negative, the effects of anxiety can be as mild as feeling uneasy to something severe like a panic attack, and range from a short incident to lasting for a long period of time. The more severe effects occur in a person with an anxiety disorder. Anxiety disorders are leading mental health issues in Canada, affecting 10% of adults. They can be caused by multiple traumatic events occurring in a person's life, but are more common in people who were shy in their early years, as well as in women. Compared to common experiences of anxiety, where a person can return to their normal state, an anxiety disorder is when a person experiences severe symptoms without being in a state of danger. They last longer and affect the person's daily living. The physical and psychological symptoms of an anxiety disorder include issues concentrating, a fear of death, trouble sleeping, heart palpitations, headaches, difficulty breathing, nausea, and more. Depression is the most common mood disorder and cause of disability, with approximately 13% of adults in Canada experiencing a major depressive episode. Depression is usually a result of various factors in a person's environment, like lack of sunlight or living in a violent home, a traumatic event like the loss of a family member or job, or even without an explanation. Depression is more likely to be experienced by women, people who have family members with depression, individuals who have experienced trauma in their childhood, people who are more emotionally sensitive, and populations who have experienced forms of oppression. Depression is twice as common in women among adults under 65, and a person is usually diagnosed for the first time in their 20s or 30s, in people who were shy in their early years as well as in women. Despite these statistics, almost 50% of people who have symptoms of a mood disorder like depression will not talk to a healthcare professional. The physical and psychological symptoms of depression include little to no energy, lack of or oversleeping, body aches, lack of appetite or overeating, weight loss or gain, feeling emotionally numb, hopelessness, lack of motivation, mood swings, poor memory, and more. Post-traumatic stress disorder, PTSD. An individual can experience trauma after being exposed to an event, often involving a serious injury, the threat of death, or death. Abusive relationships, crime, or natural disasters are additional causes of trauma. Traumatic events can lead to flashbacks, nightmares, severe anxiety, and uncontrollable thoughts regarding the situation. When the symptoms persist and worsen over a long period, it may represent PTSD. Individuals with PTSD might exhibit additional behavioral symptoms such as irritability, difficulty sleeping, problems concentrating, and avoiding thoughts, activities, or places related to the event. PTSD can lead to other mental health problems such as anxiety or depression. However, appropriate intervention can help the individual. Those with PTSD can receive help through counseling, medication, and even support groups. Eating disorders. Poor body image, low self-esteem, perfectionism, and improper stress management are all related to eating disorders. An individual with an eating disorder might feel a sense of control over their life by focusing on their weight and the components that affect it. For example, calories and exercise. There are three more well-known/common types of eating disorders, including anorexia nervosa, bulimia nervosa, and binge eating disorder. These disorders involve restricting food intake, uncontrollable eating followed by forceful elimination of the food, or periods of overeating. Other kinds of eating disorders involve avoiding restrictive food intake eating disorders not otherwise specified, and orthorexia. Eating disorders of any variety can lead to further health complications such as kidney problems, type 2 diabetes, and bone loss. Eating disorders may also be a sign of other mental illness such as anxiety and depression. Even more individuals lacking meaningful and positive support can experience the disorder. Eating disorders are treatable and individuals can recover from them by receiving appropriate care. It is important for friends and family not to react to an individual's body image comments and to be mindful of personal comments surrounding food and body image.
Thank you for listening to our presentation.
You can find more about Minds and our various prototypes at mindslondon.ca.
And thank you to all our sponsors.